I want to very briefly give you an understanding of the blood-based biomarkers being developed by Oncocyte. And this is really work that was originally led by Louise Scho and her colleagues at the Wistar Institute in Philadelphia. The general philosophy here is the use of peripheral blood genomics for cancer detection. Her original work in this space was done in circulating T-cell lymphoma, where perhaps it's a little bit more of a direct interaction of circulating T-cell lymphocytes, collecting that blood in a tube, and then being able to measure genomic differences to be able to distinguish patients with lymphoma to those who did not. Well, she took this work forward to look at solid tumors, and the idea here is that you would collect blood in a sort of Ficol gradient, isolate the white cells, isolate the RNA, and to do gene expression profiling. And the hypothesis here is that as these white cells or lymphocytes circulate through the body, they interact with whatever solid tumor you may have. We certainly know that tumors have immunosuppressive effects, and those may lead to gene expression changes, and that can be used for lung cancer detection. So this is a study that was originally published by her group in Cancer Research in 2009, showing sort of the original proof of principle around this method. And so to walk you through it very briefly, panel A is the cancer patients, panel B are the control patients. In fact, these are all my patients, since I was the person who supplied her with the sampling material. And so what you can see is that the gene expression profile is quote-unquote positive in the large majority of cancer patients and negative only in a few. I can't get the pointer to really show up on a white background here, but the few where it was falsely negative are at the end of the slide there on panel A. In the controls, you can see that most of the control patients had a negative gene expression classifier, suggesting that it has both high sensitivity and specificity. In fact, those numbers were 91 and 80% with a very robust AUC. This work then was moved forward by Louise and her colleagues to look at whether tumor removal actually changes the gene expression profile. So as you can see, at least in a majority of these patients, the lung cancer gene expression profile goes from being positive to negative after the tumor is removed, again, supporting the hypothesis that there is an interaction between tumors and lymphocytes that can be actually measured from the peripheral blood. And then they've gone on to do some work combining messenger RNA and microRNA profiles. And I've very briefly highlighted some work that was presented last year, again, using this set of combination of both messenger and microRNA, isolated from PAX gene tubes, which is a much easier thing to collect than to Ficol purify lymphocytes. You can see relatively robust sensitivities and specificities for this biomarker. So this work is being moved forward in a collaboration between Wistar and Oncocyte, and Dr. Scho will be presenting some initial work beyond what I've shown you at a session tomorrow morning at 9 a.m. on a blood-based non-small cell lung cancer diagnostic, and so I hope those of you who are interested can attend. I want to take a moment now to go through a few cases that we had sort of hoped to be able to have some time, and we have 15 minutes. This is the portion of the presentation where I'm going to ask those in the audience who manage patients with lung nodules to chime in when you want. We have a microphone that can easily float around to any of you, and I may also call on my panel reviewers here who have not seen these cases, so I get to put them on the spot just a little bit. All right, so our first case here is an 84, these are all patients of mine. So these are real cases and real situations. And in fact, some of them are ongoing, so I don't actually have an answer and can use some help. So this is an 84-year-old man with hypertension and diabetes. He's a non-smoker. He had some chest pain in January of 2014 when he had an NSTEMI diagnosed, had a cardiac stent placed at that time. He had recurrent chest pain in October of 2014 and had no EKG changes at the time. And so that led to a PE protocol chest CT. This is the first chest CT that he had ever had. It shows a lung nodule in the right upper lobe. It's 10 millimeters in diameter. His other incidental finding on the imaging study was that he had a 4-centimeter abdominal aortic aneurysm. So that's what it looks like. Tucked up into the right upper lobe, a little bit of a challenging location. I know that we don't have an audience response system, but the question for all of you and for my panelists is, what would you do next? A TTNA, a navigational bronchoscopy, a surgical lung biopsy, a PET CT, or a CT in 3 to 6 months. And so before we perhaps think about what the exact answer should be, in fact, there may not be one right answer, there probably isn't. I think this highlights a couple of points, and I'm going to maybe impose on Nicole or Peter to pick up the mic and comment on How do you go about determining pretest probability of malignancy in this particular patient? Do you prefer to use a quantitative risk model in your practice, or do you really oftentimes just use your clinical intuition and bucket them into low, intermediate, or high? And if you are going to use a quantitative risk model, which model would you use for this particular patient?
Yeah, I think this, is this on?
Yeah.
I think this case highlights very nicely some of the challenges. I use both my clinical judgment and a risk calculator when I'm looking at the a lung nodule. When I looked at this one slice, I was already challenged to say, is it really spiculated or not? It certainly is a little irregular, but spiculation is one of the factors in most of the risk models that adds a whole lot. I see little bumps on the edge. Maybe it's spiculated. I'll probably calculate it both with and without. The list of possible choices here, a couple of them depend on whether this patient can come off of their Plavix or not. It's a very, a very real life scenario where someone's been discovered to have a nodule right as they're having a cardiac procedure, and stents go in that need Plavix for 3 months or more, and you're faced with trying to manage somebody knowing already that biopsies are off the table for the next few months. So I tend to use the Mayo model first. If someone has a PET scan, the Mayo model's added to the PET scan is the Herder model, and I would use the Herder model. With that, the Herder model uses very blunt dissections of what's positive on PET. It's negative, mild, moderate, and I sometimes struggle to say, is this mild uptake or moderate uptake on my PET scan? So I calculate the probability in both ways, and I usually show those to my patients when it's a very difficult decision to make so that I can engage them and see where their values fit in the next choices.
Great, thank you. That was a great discussion. And so, based on your recommendation, I did use the Mayo Clinic model, and I got a pretest probability of 16%. What do I do now?
You talk to the patient. So he's 84, he's got cardiac disease. How well is he to get to the operating room, and how worried is he about it? So this is that low intermediate risk as you think about it. I think, you could consider ordering a PET CT scan here, which is what the guidelines say, but that's kind of dependent on where you live, and the uptake of PET is kind of different everywhere. There are some places where, as you know, they get a PET on everybody with a nodule. But it might help you here, right? So if the nodule is cold on PET scan, you might be able to reassure your patient and say, okay, well, if this is a malignancy, it's extremely slow growing because it's not taking up any FDG, and we have some time to wait here. It really depends on how worried he is. And at the ripe age of 84 with cardiac disease, maybe he would be a little less worried.
Yeah, so those are excellent comments. And so, does anyone in the audience want to make a comment on this particular case? Is it possible if I have you grab the mic, if you don't mind?
So what if it's slow growing in an 84-year-old with AAA? What is his life expectancy? Would you do more harm by resecting this versus leaving him alone?
Yeah, so I think, so it's an interesting point about if we were to know that this is really a slow-growing nodule, how we could counsel this 84-year-old who has other medical problems. This, at this point, is his first CAT scan, and it's 10 millimeters, and it might be spiculated, and I have, at this point, no idea whether it's slow-growing or not slow-growing. And so I think that's sort of the challenge of trying to determine what sort of approach do you take in conjunction with some shared decision-making with your patient about how much risk is he willing to endure? How much risk are you willing to endure as a physician? What his preferences are in terms of going through additional diagnostic testing, whether that be imaging or even a biopsy approach. He's right on the border of being able to come off of Plavix if we wanted him to for a procedure, but we would of course like to be able to continue his Plavix if possible, given his cardiac stent in about 6 months ago. So there are, some real life challenges in this particular case. I present this, mostly because I have struggled with this result on PET CT so often and this was actually the result I got on this case, which was that he had an SUV of 2.2, and the radiologist's interpretation here was that this was mild uptake, but suspicious for malignancy. We always recognize that PET scans can be very helpful when they are completely cold or helpful when they are quite hot. But in the intermediate sort of range of PET CT results, particularly when there is radiologist interpretation thrown in, where they may be sort of trying to sway you in one direction or another, even though the SUV here is only 2.2, we struggle with these decision making in this sort of case. So I found the PET CT here to be not very helpful. I suspect that, at least in my mind, his pretest probability was still sort of in the ballpark of sort of 10 to 20%. According to guidelines, I should then theoretically go forward with some biopsy. I clearly had no desire to do that with this patient, and nor did he. I perhaps would have felt better if I could have ordered one more test to be able to truly take his pretest probability from 16% down to below 10 or 5 to be able to use surveillance imaging here. And so I think that might be the role of a biomarker test. But we were able to agree for this patient that he didn't want anything done immediately. I didn't want to do anything immediately, and we were able to move forward with surveillance imaging. But again, it's a very challenging situation, and the risk of malignancy here is real and raises some concern. All right, let me jump to case 2. A 62-year-old woman, a pack and a half per day for 45 years, currently smoking a quarter pack per day. She does have a family history of lung cancer. She undergoes a low-dose CT lung cancer screening study. Again, a patient of mine. She ends up having a 9-millimeter lobulated nodule, also in the right upper lobe. Incidentally, she has a 2-centimeter thyroid nodule and some mild interstitial abnormality noted at the bases, which I'm not going to show you. There's her nodule, though, in the right upper lobe. And again, I think the question here is, what do you do next? And I'm going to impose on my panelists again to think this one through about whether you do a TTNA, a bronchoscopy, surgical biopsy, PET CT, or surveillance imaging. Maybe Nicole wants to tackle this.
I'm worried about it because it's lobulated. Her smoking history, she's a high-risk patient, given her smoking history and age in the upper lobe location. So this is probably on the high intermediate risk. I don't know what the Mayo calculator would show, but I'm concerned.
Oh.
So I might, I would present her at the tumor board to get a multidisciplinary discussion about it. And I'm assuming because she was screened, she's well enough to undergo surgical resection. And then you have to present the patient with their options. I think if I was going to order a PET CT, I would expect that thing to light up. So it would be more for staging purposes, as is the recommendation when you're dealing with a possible new lung cancer. And then, I would offer her surgical resection if my surgeon was willing to do it. But oftentimes you have a conversation and the patient says, I want to confirm that this is a cancer before I let anybody taking me to the operating room. So I think biopsy is reasonable too. I think all options are really on the table, but I'm worried.
I think that's right. So I think that all options were on the table. Peter, you have a comment?
And not much different. Again, you might use the Brock model in this patient because it was designed for this patient to estimate the pretest probability. And then I think all of your options in that intermediate range are not great for this person. PET scan, it's only 9 millimeters. Needle biopsy, bronchoscopy, not great yield because of the size. And so I think you're left with options of monitoring or taking it out. I've probably been monitoring more often than I did earlier in my career with the thought that a few months is unlikely to make a major difference, but I think talking to the patient at that point about those decisions would be the right thing to do.
So I agree completely. So thank you for bringing up the Brock model. We did use the Brock model in this particular case. There was a question from the audience. Rex Young, I've got to give you the mic for a minute. Come on up.
I can be a loudmouth and just yell out. So it's interesting, so I'm glad she's 62. Because if she's CMS and they come back to you in a year, they say you screened someone who technically did not fall under the criteria.
You're correct.
That's going to be one of your 10% ding, and you get
You're correct.
total clawback.
She was just ever so slightly out of criteria, as you point out.
22 and a half pack years.
Correct.
Right? Yeah.
Yep.
So, by the way, those of you who are entertaining screening, CMS technically you have to. It's a shared decision making. You have to advise them, and if at the end of the year more than I think it's 10%. Do not fall in the proper inclusion criteria, they can come back and really hurt your institution by paying for nothing, taking back all your screening reimbursement. But I think the main issue here is precisely, I think the PET scan, because it seems like maybe there's something in the mediastinum, in which case it wouldn't be straight to surgery, but maybe EBUS.
So yeah, I think that you're highlighting sort of the challenges of this case in that there's concern. It's a lobulated 9-millimeter nodule found on screening in a high-risk patient. So, when I ran the Brock model on this particular case, the Brock model has speculation or no speculation. So I said it was not speculated. And the pretest probability here comes out again to just a little bit over 10%. And so again, I struggled with her a fair amount because, by guidelines, it's over the 5 to 10% ballpark. I frankly did not want to do anything, though I really did think this was going to be a cancer just by its appearance, even though the model says the pretest probability here is only 10%. I think I would have liked to have been able to order another test. We certainly considered PET-CT to try and give us more information, but I talked myself out of it, and I was able to talk the patient out of it. Again, I don't love PET scans very much, and I think that we were given the probability of 10%. She was comfortable with doing surveillance imaging, so we went forward with surveillance imaging. She got a repeat scan. Oh, I keep hitting the wrong button. I apologize. Repeat scan in 4 months. I don't have the actual image, but it was stable 4 months later. And so now, the benefit of using time as a diagnostic test, I've really been able to show stability at 4 months. Now my pretest probability is clearly much lower. I don't expect this to be a cancer, and I think it's just very likely just an old granuloma. And we'll continue to follow her annually as she goes through additional screening years. Even though she doesn't quite meet criteria Rex, I won't stop the train now that I've started it. All right, perhaps do our last case. We've got sort of 3 minutes on the clock here, and we'll run through one very quick one. A 62-year-old man seen by his primary care physician for a new routine exam, a big tobacco history, some weight loss, and found to have a 1 centimeter nodule in the left lower lobe. I'm going to show you that nodule here. This nodule, the patient didn't want to do anything, even though there was a suggestion to do a PET-CT at the time that this was detected. This thing was followed with a 3-month CT, and it grew to 13 millimeters. So I'm not showing you the two different scans, but just believe me that it truly did grow by 2 millimeters. His PFTs here show that his FEV1 is below 50% of predicted, and he has a low DLCO, so both sort of severe obstruction and a severe diffusion defect. And he has a marginal oxygenation with walking 200 feet. So the questions then here are, do you do a PET-CT, a quantitative perfusion scan, a CPET, or a transthoracic needle biopsy? And again, I might put either of my panelists on the spot and see if you...
And I think another great real-life case here, you said it grew and you've not done a PET yet?
Haven't done anything yet, but it's grown 2 millimeters, and he has a 20-pound weight loss. Unclear what the etiology of that weight loss is.
Gotcha. Yeah, I mean, if this was the only site of cancer, then it would be very unlikely that he'd have 20-pound weight loss from that cancer. And so with a very high probability that this is a cancer, you may end up doing a PET scan to stage the patient and see, is this weight loss really indicating this is more widespread cancer? Beyond that, I think you have to recognize the community that you practice in. How much evidence do your surgeons need before they're going to resect something? Do they need that needle biopsy? This would be readily accessible by needle biopsy, or would activity on a PET scan with growth be enough for them, recognizing how high the probability would be? So I think you need to know your local folks and apply that knowledge when making the best decisions. The CPAT is interesting. Throw in, again, trying to make sure that somebody is fit enough to tolerate resection.
Yeah, so those are all the appropriate considerations here. And I think the one point I would make around, about once you already know that the nodule has grown here, we know that the relative probability of lung cancer is quite high. So at least in this state, or at this point in this patient's care, I don't think that there's much of a role for a biomarker test, because I already sort of presume him to be in a relatively high pretest probability, just given the growth over time and the appearance of the lung nodule. So this patient went on to a couple of additional tests. He did have a PET scan and showed that the nodule was truly PET avid with an SUV of 5.4 down at the bottom there. And he went through some quantitative perfusion scanning to try and understand whether he's a surgical candidate or not. His post-operative predicted FEV1 and post-op predicted DLCO, sort of in the middle of the slide there, were sort of, ballpark, right on the edge, right on the cusp of being able to be surgically resected. We think that you should be above 30%, and it's sort of marginal in this particular case. He, nevertheless, did go on to have a segmentectomy and had a lung cancer that was detected at an early stage, stage 1A non-small cell lung cancer, and so has done quite well. Any questions on that particular case? So, a couple points here. Once, we use time as a diagnostic tool and show that there's growth, you're in many respects have moved quite along the way from being a potentially lower intermediate risk lesion definitely up into the high-risk lesion. There are some times that you can be fooled with growth, because certain benign lesions can grow slightly, but this certainly grew at the rate that was consistent with a lung cancer in a high-risk patient, and so he moved through the diagnostic evaluation sort of pretty quickly then. Any questions from the audience at this point?
I'm Dr. Cosmas from Athens, Greece. I had a question to you. I mean, this algorithm that demands the quantitative Q-scan or the CPET is for pneumonectomy. For lobectomy, we have to do the bronchoscopy and see how many unobstructed segmental bronchi we're going to. Actually, the result is more or less the same, but I think that we have to see how many unobstructed segmental bronchi we're going to remove. So if the normal bronchial tree is about 20 segments, 19 or 20, we're going to remove the left lower lobe, which is 5. So the result is going, the post-op FEV1 or post-op diffusion, if you want, is going to be 14 over 19 of the pre-op.
So I agree completely. There is not certainly the determination of postoperative FEV1. You can use the anatomic segment method, where you determine how many segments are coming out versus divided by the number of segments, or you can use a quantitative EQ scan. The guidelines do suggest that in lobectomy you can use the method of determining segments. I don't think you have to do a bronchoscopy necessarily to make that determination. But certainly not the focus of our talk today, but I appreciate your point.
Concerning your concept about what to do, I completely agree, and I think that this patient is candidate for VATS segmentectomy or something like this.
And that's exactly what he had, I agree. Though, there was some concern of his sort of marginal postoperative predicted numbers. So that concludes the program for today. I want to again remind everyone of Dr. Show's presentation tomorrow morning at 9 a.m. regarding the biomarker that's being developed here, and we hope to see some interesting and exciting data. Thank you for your attention. Thank you to my panelists for being here and providing some very nice information on lung nodule management and biomarker development. Goodbye.